Good morning. Today I'll be giving a brief talk and discussion on invasive mechanical ventilation in COVID-19. Now, this is by no means an exhaustive talk. I'm just going to be covering some of the basics with regards to our experiences here at Critical Hospital when it comes to the mechanical ventilation of patients in COVID-19. And as we've experienced here with COVID-19 is that things are changing on a daily basis when it comes to our management and implementation of therapeutics as well as ventilation strategies. So whatever I'll be discussing today may be different in a week or two's time. So this is one of those topics where things may unfold and change as time progresses and as we learn more and more about the pathogenesis and pathophysiology behind this very interesting disease that we're experiencing currently. So on the 31st of December last year, it seems like an eternity already, the WHO reported a cluster of pneumonia cases in Wuhan. And SARS-CoV-2 was the virus that was the causative agent that we know now as the causative agent for COVID-19 pneumonia. Since then, the virus has spread to more than 100 countries, including South Africa. So it seems a while now that we've admitted our first patient with pneumonia requiring mechanical ventilation, and we've had up to over 200 patients in our ICU requiring mechanical ventilation. So this is I was about to give this talk last week, and this is just some of the cases. And you can see that there's over 13 million cases worldwide and over 500,000 deaths that were reported. In South Africa, there were 298,000 cases reported with 4,300 deaths reported. Those figures now, we've gone from, in a week, we've jumped by almost another 100,000, as well as increasing our death toll with regards to our COVID-19. So we'll keep posted as to how this unfolds and where we actually stand when this is finally over. So just a little bit about the mortality rates and mechanical ventilation in COVID. The initial studies coming out of China reported that the mortality rates were quite high, up to the region of 86%. Subsequent series in Seattle and in the States also suggested that patients requiring mechanical ventilation were also needing high mechanical ventilation, had high mortality, up to 67% in the worst case scenarios. Now, this was the study that was published in JAMA, which looked at the death toll in New York, which kind of highlighted and probably changed our management a little bit and swayed us to maybe erring on the side of the invasive mechanical ventilation, going either for high flow ventilation. And this one reported a fatality rate of 88%. Now, this is probably a little bit less than what we're actually having reported. Remember, this was for the patients still currently in ICU. So why do I think the mortality in these patients requiring mechanical ventilation is so high? So I'm going to give you some of the reasons why I think the mechanical ventilated patients do poorly. So often it's the patients with the most severe illness that will require mechanical ventilation, and it's often a salvage therapy after everything else has failed. There's been many, many different anecdotes, theories have postulated as to what the cause and pathogenesis of this disease is. And we don't quite clearly understand the pathophysiology of this illness. It's not just the disease of the lungs, and I suppose that's why mechanical ventilation doesn't always fix the issue, and mechanical ventilation mortality is high. These patients have an unpredictable clinical course. From one day they could look great to the next day not looking good at all, and part and parcel of that predicts the unpredictability of this disease also impacts on the mortality. These patients often require prolonged duration of mechanical ventilation, which itself leads to problems with regards to sedation, weakness, infection in the ICU, nosocomial sepsis, etc. Again, in our sort of resource constraint environment and capacity, we may not entirely have the resources. I think we're quite fortunate here at Curtis Care to have more than doubled our ICU capacity. But for the rest of the country now, you can see that capacity is probably a big hindrance, and also just in terms of skill set with doctors who may not actually have the skill set to mechanically ventilate these patients safely. Again, probably the trickiest bit for me in this disease process is, when do we actually intubate this patient? Do we intubate them late? Do we intubate them early? And I don't think any of us currently in this disease process knows the correct answer to that. There's a lot of patient-to-patient variability. So we can't exactly have a recipe that works for one and it may differ for the next patient. And that tends to lend itself to being quite difficult when it comes to managing these patients. And then up until probably dexamethasone has proven the most effective therapy, but there hasn't really been an effective directed therapy directed specifically against COVID-19. And these are all factors which probably all contribute to why patients requiring mechanical ventilation do poorly. So I don't have the answer to when to escalate to invasive ventilation, but this is just something that I find quite useful when I've gone to assess patients requiring the need to be put on invasive mechanical ventilation. So I've used the mnemonic GAS, which stands for gas exchange abnormality, airway protection, and secretions. Now, to use this in combination with each other, and I find that just using one is probably not sufficient when looking at answering the question whether to escalate to invasive mechanical ventilation. So when it comes to gas exchange abnormality, one of the things that we often see in the course of this disease is worsening oxygenation, whether this patient be on high flow nasal oxygen rebreather. Having a low oxygenation is often one of the indications to intubate, as well as hypercapnia, especially when the pH drops less than 7.2. And this is often not a hallmark early on in the disease, but often a telltale sign of the patient tiring and the CO2 climbing. Also, what is useful to look at is the increased work of breathing. These patients often tricky because the so-called silent hypoxemic patient may have SATs of less than 80 and still look quite comfortable. And it's quite a tricky decision as to when that actual decision to intubate. But once the patient has increased work of breathing, where they're working quite hard and they're sweating, I think that's one of the key elements to make that call. Again, if the patient has altered mental status or any change in their neurological dysfunction, I think it's one of the indicators to proceed to invasive ventilation. And then secretions, if they're very large in volume or difficult to clear, would be one of the indications. So I would use the combination of the gas exchange abnormality, the airway, as well as secretions to determine whether the patient would need to be escalated onto invasive ventilation. And then remember, we are fortunate here in our environment to have the intubation team, but remember that it is an aerosol generating procedure, and then recommended that when dealing with these patients, especially when they arrive in ICU and there's a potential for an aerosol generating procedure, to use your full airborne PPE. And then also what's quite useful is to have a so-called PPE buddy, which helps you remind you about how to doff correctly in case you forget and skip some of the steps. An important concept when it comes to any mechanical ventilation talk is the fact that mechanical ventilation is supportive therapy. It is not treatment. It is there to support the patient until you're able to offer either therapy or for the disease process to improve. But it's not there as a definitive therapy, and that's quite important. So the goal in these COVID patients is often quite tricky, and remembering that we're trying to support the system up until a point where we were able to liberate them from the mechanical ventilation. So mechanical ventilator support involves the interaction of three things, which is essentially the delivery of flow and pressure, which affects a change in the volume. And an important concept when looking at your ventilation is looking at your airway pressure. Now, your airway pressure is a combination of your flow times your resistance plus your volume compliance as well as your PEEP. Now, this is a nice schematic illustration of illustrating the airway pressures. So you can see there the blue sort of airway conducting bit, it's the flow times the resistance, which in addition to your volume and compliance plus PEEP at the alveolar level. And just as a reminder that your flow and your resistance is usually an impact of your airway pressure in your conducting airways. And in your alveolar pressure, it would be your volume over your compliance plus your PEEP. So in your conducting airways, if you increase your flow and worsen you increase your resistance, that would increase your total airway pressure, but only affect the pressure at the conducting level. If at the alveolar level, you increase volume or decrease compliance or even increase PEEP, that would increase your alveolar pressure. Okay, so that's quite an important concept. So just remember that your total pressure is the sum of your resistive pressure that's in your conducting airways, as well as your elastic pressure that's at the alveolar level. So what are the goals of mechanical ventilation? And I suppose the goals of mechanical ventilation would be similar to those in your COVID patient. So the goals would be to eliminate CO2, so to give the patient adequate alveolar ventilation, as well as to deliver oxygen. So we know that we can deliver oxygen through the high flow nasal, but the goals of mechanical ventilation is to have a ET tube in place so that you're able to then effectively deliver oxygen. It's also to reduce your work of breathing and to avoid patient dysynchrony. So the most important concepts when it comes to these goals is to remember the concept of do no harm. And that's quite important in these patients that are often on the ventilator for up to 3 to 4 weeks, is to remember that when trying to achieve these goals, remember the concept of do no harm. So we can do a couple of things in terms of harmful ventilation, so-called ventilator-associated lung injury or ventilator-induced lung injury. So you can induce volutrauma when you induce too much volume, barotrauma at high pressures, biotrauma where you essentially initiate cytokine and chemokine release, causing an inflammatory response at the alveolar level. By atelic trauma, by opening and closing alveolar units that are collapsed, you can induce atelic trauma. Shearing injury by collapsed alveoli and distended alveoli shearing over each other, as well as oxygen toxicity by providing patients high oxygen concentration can cause trauma. So again, getting back to the goals of ventilation. So how do we do no harm with regards to alveolar ventilation and eliminating CO2? And part of that is to the concept of permissive hypercapnia, where we aim for a pH more than 7.5, but we're not too fussed about an elevated CO2 as long as our pH is 7.15 and above. How do we eliminate harm? With arterial oxygenation and delivering oxygen. The sort of concept of permissive hypoxemia, where we no longer having that traditional target of greater than 92 or 94, we're aiming for saturation slightly lower at 85 to 90%, or even just the PO2 of 8. And then with regards to your work of breathing and patient comfort is the concept of analgo sedation, where we give analgesia first and then add sedation. And this is probably one of the trickiest things in our patients, where they require quite a high bit of sedation as well as muscle relaxation to avoid that increased work of breathing and just to have them comfortable on the ventilator. So a common question that we ask and we fiddle around with in ICU and get this question a lot from the registrars on the ward rounds is which mode is better and which one should be used when ventilating COVID patients. So just the background of the volume targeted mode. So we set the tidal volume and the minimum ventilator rate to set up our minute ventilation, as well as your PEEP, inspiratory flow rate. You can set a flow waveform, either square or decelerating in certain ventilators. You can set an inspiratory pause time as well as an inspiratory time, and these are all controlled when setting up in the volume targeted mode. Now remember that you can set your target tidal volume, but in the volume targeted mode, your pressure is the variable that would change. So that's just an example of what the screen would look like in a volume-based mode. You can see that you're looking at the pressure waveform, the flow waveform, and the volume. You dial in a specific tidal volume, and we'll get to how we do that in a second. An inspiratory time or flow rate, your rest rate, which would give you your minute ventilation, as well as your background PEEP and your FI2. So what are some of the good things and bad things when it comes to your volume-based mode? So volume-based mode, it's easy, it's simple to set, it avoids high tidal volume, and the one thing, especially with these patients with very poor compliance, is you can guarantee an adequate minute ventilation. The bad thing is it's often associated with quite a lot of asynchrony and discomfort, and the patient requires quite a lot of sedation in your volume controlled mode. The patient may lead your ventilator, especially if your inspiratory flow rates are too low. And remembering that a fall in compliance, when we remember that equation, a fall in compliance will result in dramatic increases in your alveolar pressure. Your pressure targeted mode, here we set a peak inspiratory pressure and a minimum ventilator rate. Here we set the inspiratory time as well as our PEEP. Now, during inspiration, the ventilator will then adjust automatically the flow rate to keep your airway pressure at the set level. And your volume is going to be variable in this mode. So just to have a look here, this is the settings in a sort of typical in your pressure controlled mode. So again, we set our FI2, our peak inspiratory pressure, and inspiratory time, your rest rate, as well as your PEEP. Now, just to remember that there's certain makes of ventilator that you would set your peak inspiratory pressure, and that would be your total pressure in terms of that 26, versus some ventilators where you would set that as the delta pressure above PEEP. So it's important to know that which ventilator you're using. So in this Draeger, you would set the total inspiratory pressure. So if you were to go up on your PEEP, your delta pressure would decrease and your total pressure would remain at 26, versus your Vela ventilator, where you would set your inspiratory pressure, and that would be your delta pressure above your PEEP. So you can see that your pressure in this mechanical ventilated mode is 26. And that's quite an important concept, just to know which ventilator and which does the delta and which does the total. So some good things and some bad things about this mode is that it's simple to set, and the one good thing is that it avoids high inspiratory pressures. Here, however, a change in lung compliance and resistance would result in a fall in your tidal volume. So things like a mucus plug or worsening compliance, you may actually not achieve your adequate tidal volume. Here also inadequate or inappropriate triggering may cause your minute ventilation to increase quite dramatically. So just comparing the two modes. So there's been studies that have been published since the early 90s, comparing the two modes. And an article published by Ritayami and others in 2015 did a comprehensive review of the published study, and it showed that there was no physiologic or clinical outcomes differences between the two modes. So what is the best mode? And probably the mode that you are most comfortable with, as well as your staff, when it comes to setting these patients initially on the ventilator, as well as the mode that works best for the individual patients. And that's going to take a bit of trial and error when setting up these patients on the ventilator. So remembering the concept of do no harm, so we want to limit overdistension of the alveoli, remembering that overdistension causes inflammation with that chemokine release and biotrauma. It then further causes organ dysfunction, which perpetuates decreased venous return and further worsening your ARDS. So this sort of concept of mechanical power, which was initially derived by Gattinoni, includes all the components that could potentially cause ventilator-induced lung injury. And Malcolm touched on this a little bit last week, looking at the various components. And what this equation tells you is that there's various aspects of your ventilator that work together, and it's not just one particular thing like the pressures that causes lung-induced trauma. So it would be your mechanical ventilation, your volume, your change in your volume, as well as your PEEP, inspiratory flow rate, as well as your respiratory rate, that can all lead to ventilator-induced lung injury. So what do we recommend? So the current guidelines recommend using a low tidal volume of using between 4 to 6 moles of predicted body weight, targeting plateau pressures of less than 30. A high PEEP strategy is recommended over low PEEP strategy, however, this is a lower, weaker recommendation. And then often to achieve these targets, we may need to use quite deep sedation or even neuromuscular blockade to be able to achieve some of these targets. So how do we calculate predicted body weight? So I'm going to go through this very quickly. So you can either extrapolate this from your BMI, 22, and work it backwards. There is quite a complex formula which is different in men and women. And you can see there's a formula for men and women. Initially, I use quite a simple formula where I use the height in men and height in women. So if you were to have a, let's say, 175 centimeter male, I would subtract that from 105, and it will give you sort of a rough estimate, so about 70 kilos. And again, once you have time, you can go back and work out or even consult the dietitians the following day as to the actual predicted body weight. But I think the most important thing when it comes to setting your tidal volume, and what this should actually just remind you of, is the fact that we're not setting your tidal volume based on your actual body weight. It's for your ideal or predicted body weight in these patients. So again, just to reiterate this important diagram, where your airway pressure is the sum of your pressure in your conducting airways, as well as the pressure in your alveolar pressure. So you've got your flow times your resistance and your volume of your compliance plus PEEP. And this is important when we're looking at working out your plateau pressures. So when you reduce your flow to 0, so you can have a look at the diagram on the right-hand side. So you've got your diagram here looking at your flow. And as your flow increases, you can see the top diagram, you reach a peak inspiratory pressure. And when you have the flow reduced to 0, you have the plateau pressure, which then equalizes, because what happens is then you don't have any flow in your conducting airways, so the total airway pressure would then equal your alveolar pressure or your plateau pressure. So remembering that your alveolar pressure corresponds to your plateau pressure, and when we reduce the flow to 0, the airway pressure would correspond to your alveolar pressure at full inspiration. You could also do an inspiratory pause or an inspiratory pause hold maneuver to be able to work out your plateau pressure. So again, just to go over that again. So this is your pressure waveform, and you can see as the flow gets delivered and as your pressure rises to reach your peak airway pressure, we do an inspiratory pause hold or an inspiratory pause, and the flow then is to 0, and you can see the pressure drops from your peak to your plateau pressure. So the pressure between the difference between your peak inspiratory pressure and your plateau pressure would be the pressure due to your airways resistance, and the plateau pressure minus your PEEP, which is also known as your driving pressure, would be the pressure required to open up your alveoli, which is related to the compliance of your lung. Okay, so just to look at that again, you've got your plateau pressure, which we get when there's no flow at the end of your inspiration. And that is a concept of the pressure that's in your alveolus. The difference between your driving pressure, your PEEP pressure and your plateau pressure is your driving pressure, which relates to the compliance at the level of the alveolus. So again, plateau pressure minus your PEEP would be your driving pressure. And this tells you about the compliance in your respiratory system. So the higher your tidal volume and the lower your compliance, the higher your driving pressure would be. So Amato did a study looking at the predictor of mortality in patients with ARDS and subsequently showed that mortality was improved when the driving pressure was targeted below 13 to 15. So anything below 16 is associated with a low mortality. So this is something, I think there's a little bit of confusion with regards to our plateau pressure in our pressure cycle mode. So how do we actually calculate that? So again, remembering the diagram that we had initially, where your total airway pressure is equal to the pressure in your conducting airways as well as in your alveolar pressure. So in our pressure-based mode, we dial in a total inspiratory pressure, which then takes into account our conducting airways as well as our alveolar pressure. So we've got two diagrams here, both in our pressure cycle mode. So the one on the left, A, so you can see that here we've got a patient with low airways resistance, and the peak pressure here in a hold mode, your peak peak would coincide with your peak plat. So you can see there, the flow comes down to 0, and the pressure that gets delivered is very similar when we're doing a hold in this patient. So this is a patient where there isn't a lot of pressure that's being contributed by the conducting airways. The one alternative on B, in patient B, you've got a patient here, you can see that the flow gets generated over a very short time. So there isn't time to get to the end of your flow, and this shortens, and you don't actually reach your alveolar pressure. And you can see when we do an alveolar, a hold, that there's a difference between the pressure, between our peak pressure and our plateau pressure. And you can see the gray shaded area in this instance tells you about the airway resistance. So the flow and the resistance in the conducting airway is contributing a little bit more. So you can't use your total inspiratory pressure in patient B as a measure of your P plat, as your P plat is much lower than your total pressure. And we'll take some questions. I know there's probably going to be some confusion over that. So just to reiterate, so your peak pressure in your pressure controlled mode would be similar to that in a patient with low airways resistance with a normal flow. And in patient B, where there's a higher airways resistance, your P plat would be lower than your total pressure that you're dialing. So remembering that COVID-19 is not a typical ARDS. So not a one-size-fits-all option. And Gattinoni and Ciumello looked at patients that had relatively preserved compliance with reduced shunt fraction, which is different to the normal ARDS type picture. And they included 150 ventilated patients, and they saw that more than 50% of some of these patients retained normal lung compliance, and they proposed two primary subtypes of so-called CARDs, the type L and the type H. So here just looking at, this is the same patient. The patient on top is a CT scan done in the patient on oxygen, and patient B is the same patient now requiring mechanical ventilation. And these were just CT scans done, the one looking at the similar degree of hypoxemia. You can see the PF ratios are similar, but markedly different amount of aerated lung. And essentially, what he suggested that over time, this sort of villi and unchecked viral disease incites this inflammation, edema, local and generalized thrombogenesis, cytokine release, right ventricular overload, and systemic organ dysfunction. And came up with the two concepts of the phenotypes L and H, where they saw that there was, in the L-type phenotype, there was low elastance or near normal compliance, low VQ and loss of hypoxic vasoconstriction, low lung weight, and low lung recruitability, versus the patient which had the H-type, which is more typical of your ARDS that, as we know it, with high elastance, with reduced compliance, a high right to left shunt, high lung weight, and high lung recruitability. So they suggested that for the type L patient, that these patients often respond to reversal of their hypoxemia, and high oxygen concentration may be effective early on. Important to monitor the work of breathing in these patients to prevent the so-called PEEP concept. And they suggested that early intubation may stop the progression to type H. Now, there's been some controversy lately, especially with regards to early intubation, whether or not this is appropriate or whether this actually holds true. So they've suggested that once intubated, the patient then can be ventilated with slightly higher tidal volumes, and then prone positioning may not be helpful in this situation as the patient has compliant lungs, and then to aim for a slightly lower PEEP strategy in this instance. So the concept of PEEP, which is a patient self-inflicted lung injury, which essentially is caused by the patient having these high respiratory drives causing tidal strains effective to the vulnerable tissue of the lung. And this essentially causes stress and pulmonary pressures and leakage in the lung tissue. And hence they found the need for deep sedation and neuromuscular blockade, which may disrupt the cycle. They suggested that the management for type H would be treated as a more traditional ARDS. We would give these patients a lower tidal volume, high PEEP, target our plateau pressures of less than 30, and if they don't respond, to prone these patients for up to 16 hours. So how do we troubleshoot once we've started these patients on mechanical ventilation? So when we've got our peak airway pressure alarms going off, I think important to realize, is it a problem with the total airway pressure, or is it a problem with the alveolar pressure? So the first thing to do is to make sure your dope's pneumonic. So is the tube displaced? Is there a need for suctioning? And then important to check the plateau pressure. If your plateau pressure is normal, then it potentially could be a problem with either reactive airways disease or potentially a kink or biting on the tube or blockage. Evaluate for pneumothorax. Now, you can either do this with an ultrasound, which is quite sensitive, looking for the absence of your seashore sign, and you could utilize the chest X-ray as well. So this was just an X-ray done on a patient that we were looking after at Somerset Hospital that deteriorated quite badly, and peak airway pressure shot up and increased the PEEP and went through all the necessary. And unfortunately, this X-ray was done just prior to the patient arresting and the patient subsequently demised. So just remember that in your pressure-based mode, you may not have your pressure alarm going off. You will only see a drop in your tidal volume. And what about high alveolar pressures? Now, this can be caused by excessive tidal volume. So remember to target your 6 moles per kg ideal body weight in these patients and not the actual body weight. It could be caused by gas trapping, especially if you're going with your higher respiratory rates and causing an inverse ventilation ratio. Overdistension can also be caused by PEEP, as well as a low compliance. Now, in ICU, some of the things that can cause low compliance is either the lung itself fluid, pneumonia, infiltrates, etc. Remembering that equation that we spoke about, that your alveolar pressure is what's happening at the alveolar level with regards to volume, compliance, as well as PEEP. So what can we do if the plateau pressures are more than 30? And reduce the tidal volume? I would say to go to a minimum of about 4, remembering that here you may have increase in your CO2. To remember to target your pH above 7.15. If the patient has a positive fluid balance or is hemodynamically stable, you can consider giving the patient a diuretic, or even consider starting the patient of neuromuscular blockade if they haven't been started already. Just remembering also auto PEEP or gas trapping, you may want to adjust your respiratory rate 2 to 6 to avoid your gas trapping or auto PEEP. What happens if the patient is acidotic? So the first thing would be to evaluate whether or not the acidosis is metabolic versus respiratory. So to check the anion gap, the lactate, you would then increase your respiratory rate and to lower your CO2. But remember that if you go to a respiratory rate of more than 30, you will need to decrease your inspiratory time to avoid an inverse inspiratory-expiratory ratio. Also monitor for auto PEEP. This is probably the most common scenario that we have in these patients, is that refractory hypoxemia. Importantly, you have time to consult an expert, preferably your consultant or senior registrar. Consider proning in these patients and also the use of recruitment maneuvers. However, it should be known that the patient should be hemodynamically stable prior to doing these recruitment maneuvers, and to limit the amount of recruitment maneuvers that you are doing on these patients on a daily basis. Remembering that the recruitment maneuver itself can cause barotrauma and polytrauma, and to always ensure that the patient is stable throughout with adequate monitoring. Another important aspect to consider with patients with refractory hypoxemia is their cardiac function. It's been reported that up to 30% of patients with COVID pneumonia have impaired cardiac function with either as a result of myocarditis and cardiomyopathy. As many of these patients are also prone to ischemic heart disease, with having underlying comorbidities such as diabetes and hypertension. You may need to restart your neuromuscular blockade in these patients that are having difficulty in oxygenation. And then as a last resort, to consider patients for VV ECMO. We've recently put a young lady onto VV ECMO who we were struggling with ventilation and oxygenation. And just a little bit about proning. So we've used this quite successfully in our ICU with the COVID patients, and it should be limited to the patients with severe life-threatening refractory hypoxemia, as there are some downsides and disadvantages to proning patients. There has been shown to be a mortality benefit in patients with a PF ratio of less than 100. And the Placebo trial done in 2013 showed that there was a marked mortality benefit, a number needed to treat of 6 in patients with severe ORDS. So a 28-day mortality was shown to be 16% in the patients that were prone versus patients that were supine, having a mortality of 32.8%. They suggest doing prone ventilation for up to 16 hours, and just remembering, again, the hemodynamics and pressure areas in these patients when doing the proning, and to have a plan and a team dedicated to proning these patients. So what are the physiological effects of proning? It's postulated that it optimizes your VQ mismatching, therefore increasing blood flow to dependent lung. It increases your functional residual capacity and reduces areas of atelectasis, thereby improving alveolar ventilation. Your heart now sits against the sternum rather than the left lung, and therefore that portion of the lung is less compressed. There's also decreased transpleural pressure gradient between the dependent and non-dependent lung in the prone position. Your plateau pressure is also more uniformly distributed when prone, resulting in a more uniform alveolar ventilation. So lastly, some concepts beyond the ventilator and invasive mechanical ventilation in these patients is to avoid a positive fluid balance or hypovolemia. In these patients, it needs to be remembered that you may require deeper sedation in a lot of these patients. We routinely thromboprophylax our patients fully with low molecular weight heparin, as these patients are of greater risk of venothromboembolic events. Remembering that now with the advent of using steroids such as dexamethasone, these patients all require ulcer prophylaxis and good glucose control during their ICU stay. And then importantly, to provide the families with frequent updates telephonically or via video calls, as often these patients haven't been in contact with their loved ones for quite a significant length of time during their ICU stay. And then just as a reminder that although we've got the two various types of subtypes, phenotypes of COVID pneumonia, that you should tailor the therapy to the individual patient. And there's probably a wider spectrum of disease in these individuals. And remember the concept of do no harm. So just some take-home messages. So when dealing with these patients in the ICU, especially when dealing with aerosol-generating procedures, your safety is paramount. Remember that mechanical ventilation is a supportive therapy. It's not treatment. And during that time, it's important to remember the concepts of do no harm. Although mechanical ventilation in COVID-19 carries a high mortality, there are still many success stories that we've had in ICU, and it's not always dire. Stick to what you and your staff are familiar with, and remember, it's not a one-size-fits-all approach. Avoid your ventilator-induced lung injury, and remember the concept of do no harm. So aim for your permissive hypercapnia, your permissive hypoxemia, as well as reducing your work of breathing and the synchrony on the ventilator. Important when setting your ventilator to go back, assess and reassess these patients, whether it be from a hemodynamic monitoring point of view or with your blood gas analysis. Consult an expert in the field early if you are struggling with these patients, and remember, be safe. Thank you so much for your attention.